Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar. My name is Kelsey Gregory, and I will be today's moderator. The webinar is entitled Breath of Fresh Air, the latest puff of COPD updates. We are thrilled to have Dr. Danielle Cabral as our guest who will present. Dr. Danielle Cabral is currently a clinical pharmacy specialist at Northwell Health Division of Allergy and Immunology in Great Neck, New York, where she initiated clinical pharmacy services for patients with allergies, asthma, and primary and secondary immunodeficiencies. After graduating from Touro College of Pharmacy in 2018, she completed a PGY2 residency at Plainview Hospital and a PGY2 residency in ambulatory care with a focus in HIV/AIDS at Northwell Health Division of Infectious Diseases. In 2020, Dr. Cabral began practicing as a clinical assistant professor within the Department of Pharmacy Practice at Binghamton University School of Pharmacy and Pharmaceutical Sciences, where she taught didactic and experiential students for 3 years and continues to teach as an adjunct professor. She is CDTM and board certified, a practicing HIV pharmacotherapy specialist, and is currently an NYSCHP delegate. Outside of pharmacy, Dr. Cabral enjoys spending time with her dog and nieces, reading, and traveling. Before we get started, I'd like to share a quick points. For those who have technology issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you'd like to direct to the speaker, please use the question box or chat option. The CE code for the program will be provided at the end. And now I'd like to present Dr. Cabral for the presentation.
Thank you so much for that wonderful introduction, Kelsey, and thank you everyone for joining today. I am very excited to have the opportunity to present this CE on COPD updates for you all. I have no relevant financial disclosures to present. And for the objectives, I have provided both pharmacist and technician objectives just to basically go over the updates on the GOLD report, going into really the differences in therapeutic management that we're really focused on, as well as the differences in classes that will be touched upon. And so with that, we're going to go into chronic obstructive pulmonary disease and our overview of it. And so chronic obstructive pulmonary disease, or COPD, it is a heterogeneous lung condition that is characterized by chronic respiratory symptoms, really dyspnea, cough, sputum production, and/or exacerbations that result from airway abnormalities such as bronchitis or bronchiolitis, and/or alveoli abnormalities, including emphysema. And the combination and/or presence of either of these abnormalities really results in persistent, often progressive airflow obstruction. It is preventable and treatable. However, it is one of the top 3 causes of death worldwide. It does have a combination of causes, and the interesting factor that the GOLD report has posed in terms of the factors that cause COPD is now termed as gatomics, which is the gene-environment interactions over time or the lifetime that leads to damage and/or altering of the normal aging process. It's this new terminology that was posed in the 2023-2024 report that they are continuing with, showing this combinational factorial effect on the body that really leads to this development and effect in our patient population. The most common causative factor that we tend to see in our patients is really environmental, and we tend to see in high-income countries, about 70% of our patients will develop COPD from tobacco smoke or noxious particles and gases from pollution. Most of that is really smoking induced. However, in lower income countries, this can actually occur from biomass exposure, wood or animal dung or crop residue, or even just poorly ventilated stove exposure. There's also the factors of genetics that comes into play. And while there are some other genetic mutations that do have a role in the development of COPD, the most common, or I should say most well known at this point, is the SERPINA1 genetic mutation, which is the most relevant, although it is epidemiologically rare. But this genetic mutation is well known to actually lead to the development of the alpha-1 antitrypsin deficiency. And so, as I said, it's this combination of both environmental and genetics and that additional time factor that leads to this development of COPD in an individual's lifestyle. So in the United States, it is one of the top 10 causes of death. About 16 million United States adults do have COPD. However, there are probably many more who are unaware of their diagnosis and have yet to be diagnosed. The prevalence is stable and thankfully has been stable from 2011 to 2022. However, there is a slightly higher prevalence in women, which could be just due to the socioeconomic factors of women having a higher exposure to chemicals and just due to the lifestyle exposures of choices and unfortunately what women may necessarily have to do in households that men may or may not have to be exposed to. Thankfully, death rates among 45 and older have decreased from 1999 to 2021, both overall and among men. And the difference in death rates between males and females has also decreased since 1999, which is a great plus. Globally, they would say the prevalence is estimated to be about 10.6% as of 2020, but that I would also say is a great underestimate, as this is still, there are a lot of individuals who are unaware of their diagnosis, and a lot of individuals are likely not presenting to the healthcare professionals to be assessed for their symptoms. So prevalence in 2022 in the United States, as you can see, it does vary throughout the United States, ranged anywhere from 3% in Hawaii to about 12% in West Virginia. We do have a pretty high prevalence in the Midwest to some states in the South, and this could just be to a higher prevalence of tobacco smoking in those areas. The deaths also are notably different by states, but thankfully, as I said on the previous slide, deaths thankfully have decreased overall. So in terms of the GOLD updates, there was a major change from GOLD 2023, where it was calling attention to the gatomics, acknowledging etiotypes and the phenotypes of the specific types of COPD, and really focusing on diagnostic considerations. In GOLD 2024, they wanted to refine that taxonomy, look at the treatment impact on mortality, look at adherence considerations, the importance of inhaler and device selection, look into role of CT imaging, and assessment and management of exacerbations. The 2025 GOLD updates has really only further refined upon this and has further enforced the importance of inhaler and device selection and adherence considerations in patients. So proposed COPD taxonomy in our individuals, they're basing it into the causes of what is that underlying cause of the COPD. There is COPDG, which is a genetic cause, generally alpha-1 antitrypsin deficiency. Generally, it's a low concentration, less than 20%, which is highly suggestive of a homozygous deficiency. Most individuals or anyone who is diagnosed with COPD should be screened for alpha-1 antitrypsin deficiency just to see if there is this genetic component to it. There is also COPDD, which is any type of abnormal development component. Generally, this would be an individual who was either born premature or born low birth weight. This can contribute to the development of COPD just from that initial hindrance during their development and through their childhood. There's also COPD-C, which is our most common, cigarette smoking or tobacco. This can be from either exposure in utero, passive smoking, vaping, e-cigarettes, as well as cannabis. We have COPD-P, which is that pollution or biomass. We have COPD-I, which would be COPD resulting from infections, childhood infections, tuberculosis-associated COPD, as well as HIV-associated COPD. COPD-A, which is COPD asthma. This tends to occur particularly in childhood, and it can have that correlation where asthmatics develop this combination developmental issue that then leads to the development of COPD later on in their life. And then the last taxonomy is COPD-U, which is COPD unknown. That last box where they're really unable to identify what that cause is. There's also an additional method of identifying a person with COPD that they're proposing, which is a method of saying, do they have early COPD, mild COPD? Are they young COPD, pre-COPD, or do they have PRISM? Early COPD is a more difficult type of COPD to diagnose, where it's referring to more of the biological first steps of COPD. It's referring to the actual changes in the body that are occurring that lead to structural abnormalities and lead to clinical symptoms that an individual experiences. It's not the actual structural abnormalities or the symptoms that they are experiencing. It's those changes that are occurring prior to that. So it's more of an experimental setting that was posed and less likely to be used in an individual, but it was posed by Gold. We also have mild COPD, which would be somebody who would present with an FEV1 that's actually greater than or equal to 80%. So they have a less obstructed airflow via spirometry. There's also the premise of young COPD, where we're seeing individuals presenting with COPD younger, 20 to 50 years old, who may have significant structural and functional lung abnormalities, who may have never achieved normal peak lung function. They may have had early lung function decline. And it's not necessarily mild COPD because they could have a lower FEV1, but they're younger than you would expect them to be. We also have, we tend to see a history of respiratory disease in these individuals. We're seeing a lot of early hospitalizations, and we just tend to see a very common history of infections in these individuals that really tends to lead to this early diagnosis in young COPD. There's also pre-COPD, which is where we're identifying an individual who's at risk for developing COPD. They're experiencing symptoms and or identified structural or functional abnormalities. However, their spirometry is not necessarily identifying any airflow obstruction. So their spirometry is normal. However, they have the symptoms of dyspnea and wheeze, but their airflow is fine. They could actually go on to develop COPD, or they may not. But there's somebody who you could consider diagnosing or terming them as pre-COPD. And then the last group is PRISM, which is preserved ratio impaired spirometry, which would be an individual who has that preserved ratio of that FEV1, FVC greater than 0.07 after bronchodilation, but their spirometry is still less than 80%. So they have higher than that FEV1 over FVC that we would term us as a COPD diagnosis, but they're still getting that airflow obstruction. So for clinical presentation of our patients, generally we're seeing dyspnea, we're seeing wheezing, fatigue, cough with or without sputum production, a lot of recurrent lower respiratory infections, and we're seeing just a lot of acute exacerbations in these patients. So how do we diagnose them? A lot of times we're looking at that airflow assessment first and foremost. We're looking at that FEV1 over FVC. So that forced expiratory volume over 1 second over that forced volume capacity. Generally, anything less than 0.07, that's going to give us that confirmed diagnosis of COPD. Once we look into their FEV1, we can break them down into their GOLD categories. If their FEV1 is greater than 80%, they're having a more mild presentation of COPD, they're GOLD 1. If it's at between 50 and 80, it's more moderate, it's GOLD 2. If it's between 30 and 50, it's more severe, it's GOLD 3. And if it's less than 30% of what's predicted, it's very severe, and they're now considered GOLD 4. Generally, any patient who comes in with dyspnea, chronic cough, sputum, and or any risk factors of COPD, we should be considering them for spirometry testing and considering them for diagnosis of that. So after spirometry, using these diagnostic criteria, the modified MRC scale, as well as the COPD assessment test, looking at their symptoms and the severity of their symptoms, assessing how severe is this and how severe is it affecting your day-to-day life, we can now combine this into our new COPD assessment tool. Prior to 2023, we had an ABCD assessment tool. They have now combined C and D into our new ABE assessment tool. So we take our post-bronchodilator FEV1 over FVC of less than 0.7. That's our GOLD diagnostic criteria of COPD. We then assess their airflow obstruction, whether they're mild, moderate, severe, or very severe. And then we look at their symptom and exacerbation risk. If they've had no or one moderate exacerbation that did not require hospitalization, their symptoms are not that bad. Their MMRC and CAT score is pretty low. They're going to fall into a group A. Once they have a higher symptom level, CAT scores greater than 10, they're going to fall into that category B. They're going to require a bit higher in terms of their management. Once they've had more than 2 moderate exacerbations annually, or they've had 1 exacerbation that led them to be hospitalized, they're immediately going into category E, regardless of what their symptoms are. And so those individuals are going to require a bit more management, and we're going to treat them with more therapeutic tools than we would groups A or B. And I'll go into that on the next ones for you. So when we're looking at our patients, we should consider some additional assessments. We have smoking status. We want to look at, are they smokers? And we should really be recommending cessation for them. If they are smokers, we want to stop it. That's really a key factor for their likely the severity of their smoking, and we need them to stop it. Their vaccinations, we want to assure that their appropriate vaccinations are up to date. Their blood eosinophilic count, we need to ensure, we need to assess how high are their blood eosinophils, because what we've come to learn is that these are actually a predictor of our therapeutic choices in these patients. So higher patients with higher eosinophilic counts are actually eligible to receive certain therapeutic regimens that patients with lower eosinophilic counts may not be eligible to receive. Individuals, particularly with higher eosinophilic counts, are generally more likely to benefit from inhaled corticosteroids than those with lower eosinophilic counts. So that would be something that would direct us versus if we don't have that number for our patients to assess them. Another thing would be comorbidities. We want to look at particularly, do they have cardiovascular disease? Do they have metabolic syndrome? Do they have osteoporosis or depression and anxiety? Because all of these can actually impact mortality and hospitalization independent of the airflow obstruction of them and put our patient at further risk than we have to worry about in addition to their COPD. So how do we go about managing our patients based on their therapeutic ABE category? If we have them and we've decided that based on their moderate exacerbations with no hospitalization, they've had a low MMRC and a low CAT score, they're group A. We can give that patient a bronchodilator. At that point, we're going to be offering them a SABA or a LABA. We can pick either in that case. Generally, we're going to want to go with a LABA just because it is preferred, unless your patient is really presenting with very occasional breathlessness. If they are really presenting with that occasional breathlessness, then a SABA may be the better option for them. And if it's better optional cost-wise and affordability. However, if they're experiencing more breathlessness and this is more affecting them on the day-to-day, you're going to want to go with that LABA because it's going to offer them that more long-term effectiveness to give them that daily benefit that they really need. Once they get into that group B, where their symptoms are now affecting them daily and it's limiting their daily activities of life, we're going to want to consider utilizing both a LABA and a LAMA, so a long-acting bronchodilator and that muscarinic antagonist. And in terms of randomized controlled trials, we've seen that in patients with less than one moderate exacerbation with a CAT score that's been greater than 10, that combination of LABA and LAMA is actually superior to just a LAMA alone. If a patient is unable to get LABA and LAMA, say for formulary issues or insurance deems it inappropriate, there's no preference over LABA or LAMA. You're going to pick based on your patient's symptoms. So are they presenting with more sputum production that you might want to go with a LAMA over a LABA? Are they presenting with more dyspnea and inflammation? The LABA may be better. And so individual preference may be best, but either way, you would really want that combination benefit just because that really has shown the most benefit when it comes to treating these patients and proving the most helpful in reducing exacerbations and reducing hospitalization. And then once we get to any more exacerbations or any hospitalization at all, we get to our group E. And at this point, we're doing at least a combo of a LABA and a LAMA. And if not, we might even consider adding on an ICS for triple therapy if they have that high eosinophilic count. So at that point, if their blood eosinophilic count is greater than 300, we're adding on that triple therapy. And similarly, a systematic review and a meta-analysis also showed that in this case, a LABA and LAMA really, truly the most effective to reduce these exacerbations and really the most effective to reduce hospitalizations. We don't want to utilize a LABA and an ICS just because it does tend to increase the risk of infections and pneumonia. So we don't want to utilize it unless they have those elevated eosinophils and unless your patient has asthma. If they have COPD, there's no reason that they should be getting ICS unless they have those elevated eosinophils, because otherwise the risk of it is just not that beneficial. Now, in all of these categories, whether we're using a combo or triple therapy or just a regular bronchodilator, we do always want to consider a single combination inhaler or just a single inhaler in general. because it's likely going to be more convenient and more effective for your patient to improve adherence to therapy. We want to make sure that they are able to utilize the therapy, they're able to use the inhaler, and we should always be assessing by reviewing their symptoms, review their inhaler technique, review their adherence, and adjust the medications as needed, either escalating up therapy or de-escalating if possible. But really, assessing that inhaler technique is so important. And if we need to switch the inhaler to something more patient-friendly, that's a key factor that needs to be taken into account. So I just put these slides in just for a reminder for everyone in general. The bronchodilators, we have our SABAs, we have our LABAs. We have for our SABAs, our short-acting bronchodilators, our albuterol, our levoalbuterol. I did provide the delivery method just so you're aware of our meter dose inhalers and our dry powdered inhalers, just because it can really impact if your patient is able to tolerate the inhaler and whether they're able to tolerate it. So our long and short-acting bronchodilators, these do alter airway smooth muscle tone and they widen the airways, so they do improve that expiratory flow. Generally, though, in COPD, we do not recommend the use of SABAs on a regular basis. And LABAs overall, they do significantly improve lung function. It does assist with dyspnea, health status, and it can really reduce exacerbation rates in general. So overall, a good choice for your patients with COPD. And then we have our anticholinergics, our short-acting, our ipratropium, and then we have our long-actings, our aclidinium, tiotropium, umeclidinium, and then revefenacin. Our LABAs and LAMAs, both also the LAMAs just as much as the LABAs also significantly improve lung function, dyspnea, health status. And our LAMAs actually have a greater effect than our LABAs in reducing exacerbations than LABAs, surprisingly enough. And they do also decrease hospitalizations just a bit more when it comes to the comparison of LABAs, but just as effective when it comes to your patients. The only thing to keep in mind, though, is that a lot of the LAMAs are only available in DPIs. So it is something to keep in mind where if you have a patient who is not able to manage a DPI, that is going to be problematic. And I will get into that in the end of the presentation. So I do have some combo bronchodilator and anticholinergics here for you. We have the albuterol ipratropium. We have our LABA/LAMAs, formoterol aclidinium, vilanterol umeclidinium, olodaterol tiotropium. When it comes to our SABA/SAMAs, the combination is actually superior to either a SABA or a SAMA alone in improving both symptoms and FEV1. So the combo is a great option when you're using the patients. And the combination of the LAMA and LABA does also increase FEV1 and reduce symptoms compared to monotherapy. So again, having that combination really is a huge benefit when you're treating these patients, especially if it isn't a single inhaler, just to provide them that full benefit of it. Then we have our combo inhalers with corticosteroids. A lot of these we tend to see more, especially the LABA with ICS in our asthma patients, but we can see our LABA/LAMA ICS in our COPD patients. Generally, as I said, our ICS, we should be reserving these in those who have a higher eosinophilic count because they do increase the risk of pneumonia in those who have a severe risk. But in those who have those higher eosinophilic count, that triple therapy does improve lung function, does improve symptoms, and can reduce exacerbations. So when would you consider ICS and COPD? You'd strongly consider it if they have that history of hospitalization for exacerbations, more than 2 moderate exacerbations per year, that high blood eosinophilic count greater than or equal to 300 cells per microliter, or if they have a history of or concomitant asthma. You might consider it if they have 1 moderate COPD exacerbation per year, or if their blood eosinophils are between 100 to less than 300. However, I wouldn't consider it if they had repeated pneumonia events, a blood eosinophil count of less than 100 cells per microliter, or if they had any history of mycobacterial infection. At that point, I'm going to want to avoid it in those patients because it's going to be more harmful than good. So in our patients that we're managing, once we get them started on therapy, we're going to assess their management of their disease state. They're likely going to still present with symptoms. And if they're not, fantastic. They're doing great, great. But if they're not, you have to manage them and figure out what's the next best step. So if they're still presenting with dyspnea, if they're on a LABA or a LAMA, move them up to dual therapy. After that, consider switching over your inhaler and just start switching over, implementing new devices, possibly trying different devices, because it might just be the patient not getting the proper device technique. Whereas if it's exacerbations that they're having, there's kind of an algorithm that you should follow. If they're on a LABA or a LAMA and their blood eosinophils are elevated, greater than 300, let's move them up to that triple therapy. From there, we can go 3 ways if they're still having exacerbations. You can either go to roflumilast if they have an FEV1 less than 50 and they're presenting with chronic bronchitis. You can consider a Zithro if they're a former smoker. And we have some alternatives, which I'll discuss for you. Or if they were on that LABA or LAMA and their blood EO was less than 300, again, bump them up to that duplicate therapy. And then from there, if their blood EOs were less than greater than 100, consider that dual therapy, triple therapy. And then if they had that eosinophil count less than 100, you can consider these alternatives again. So the alternatives that I was mentioning, let's go into them. And if you have a patient who has both dyspnea and exacerbations, you'd want to manage them as if they were on the exacerbation pathway in general, because you want to treat them a little bit more strictly. So roflumilast is one of our PDE4 inhibitors. It's a once daily oral medication. Generally, this is going to be considered in patients who are not controlled on a LABA/LAMA or on triple therapy, who have lower eosinophils, chronic bronchitis, they have an FEV less than 50, and generally, they were shown to be in a study that in patients that it was studied in, they did reduce moderate to severe exacerbations for patients requiring systemic corticosteroids. And those patients had chronic bronchitis, severe or very severe COPD, and an exacerbation history. The side effects of it can be a little limiting: diarrhea, nausea, reduced appetite, headache. But the side effects do tend to occur early on and are reversible and can diminish with time over use. Antibiotics, we have had some mixed use and mixed results with this. Previous studies really showed no effect of continuous prophylactic macrolides. However, now we've seen some benefit, may reduce exacerbation rate with macrolides. So azithromycin 250 milligrams daily, or 500 milligrams 3 times weekly, or erythromycin 250 milligrams twice daily for 1 year. The benefit would be more in a previous smoker, as there is a reduced benefit in an active smoker. But again, with our antibiotics, we worry about bacterial resistance, QTC prolongation, impaired hearing tests, and there's really no benefit seen with fluoroquinolones and tetracyclines. So what other options do we have? We worry with these patients who are presenting with these continued symptoms because we're finding that a lot of these patients are presenting with type 2 inflammation. Up to about 40% of patients have this type 2 inflammation. And this inflammation is really associated with an increased risk of exacerbations. we're finding that they have elevations of IL-5, IL-4, IL-13, type 2 helper T cells, as well as type 2 innate lymphoid cells. And these elevated cells can lead to elevated eosinophilic counts in the sputum, the bronchial tissue, and the blood, as well as elevated levels of fractional exhaled nitric oxide, or FeNO, which also leads to elevated inflammation and has a correlation with elevated risk of exacerbations. So type 2 inflammation generally has a generally better response to glucocorticoids, and IL-5 does drive eosinophilic maturation and survival, as well as IL-4 and 13 does increase FeNO level, promotes eosinophil and type 2 inflammatory cells infiltration into the lungs. So by targeting these particular cells, we may be able to reduce these levels and reduce the risk that our patients are presenting with. Infliximab was the first biologic that was looked at for our patients, and unfortunately, this was a bust. It was assessed in patients with moderate to severe COPD from 2003 to 2004. It was a 1-to-1-to-1. They basically looked at a chronic respiratory questionnaire improvement. Medication was generally well tolerated. However, no benefit was shown with the medication. They found no benefit in the pre-bronchodilator FEV1, no benefit in the 6-minute walking distance, and no change in the moderate to severe exacerbations with this medication. They also found a possible increase in malignancy with this medication. And so because of that, they realized infliximab may not be the way to go. So they've moved on to mepolizumab. This is an anti-IL-5 monoclonal antibody given by subcutaneous injection, studied for eosinophilic COPD. Initially, they had done 2 phase 3 randomized placebo-controlled double-blind parallel trials, METREX and METRIO. They were studying them in COPD with a history of moderate to severe exacerbations while on triple therapy with eosinophils either greater than 150 and greater than 300. However, in these trials, they found inconsistent results. In METREX, they found that in eosinophilic COPD, the annual rate of exacerbations did decrease with mepolizumab, and it was statistically significant. However, non-eosinophilic COPD, there was no benefit with mepolizumab. In METRIO, there was no significant, it was a statistically non-significant decrease for both the 100 and the 300 milligram dose for both of the doses compared to placebo. From there, they found that there was a greater effect seen on the rate of reduction when the individuals had a higher blood eosinophilic rate at screening, but they weren't sure what to make of this. And they realized that they did want to look into this a bit more. The most common side effects were worsening of COPD, nasopharyngitis, headache, and pneumonia. So they did actually create a new trial, and there is currently a phase 3 matinee trial ongoing, looking at individuals greater than 40 with 1 or more moderate or severe exacerbations in the previous 12 months, optimized on triple therapy for at least 3 months, eosinophils greater than 300 at screening, and at least 1 historical visit with a level of greater than 150. So they're looking at mepolizumab now to see if there is any benefit still in these individuals. So we'll see if that is a potential that we can see, because this is a sub-Q injection given every 4 weeks. There's also benralizumab, which is a sub-Q injection. It's an anti-IL-5R monoclonal antibody. This was studied in the Galathea and the Terra Nova trials. Initially, they were looking at individuals with greater than 220 eosinophils and less than 220 eosinophils and found inconsistent results. They found that there was a decrease in the annual rate of exacerbations with the 100 milligram dose that was statistically significant in Galathea, but in no statistically significant decrease with the 30 milligrams. However, in Terra Nova, no statistically significant decrease with any dose that they tried. And they unfortunately found eosinophilic depletion with every dose that they were looking at, which is terrifying because that does put your patients at a higher risk of infection. They have then looked into this a bit further, and they now have a phase 3 trial called Resolute, which is ongoing, looking at 40 to 85-year-olds with moderate to severe COPD, more than 2 exacerbations in the prior year, also on triple therapy for at least 3 months. Now looking at a higher blood eosinophilic count, very similar to mepolizumab, with at least 300 cells at entry into the study itself and at least 150 cells historically. So they are looking into this. This would also be very interesting to see what the results are, because this is an every 8-week injection that could potentially give individuals a bit more length of time. Then we have Dupixent, which is where we're at nowadays, which is an anti-IL-4, IL-13 monoclonal antibody. This is, I think, the golden child of the biologic world. It just last week got another indication of chronic spontaneous urticaria, and it's the first biologic approved for use in eosinophilic phenotype COPD. And it was from the Boreas trial and the Notice trial, which I'll go through. And so the inclusion trial I have here for you, really just individuals with moderate to severe COPD, looking at post-bronchodilator FEV1 30 to 70 on that triple therapy, high blood eosinophilic count greater than 300, high exacerbation rate. Their patients were about 65 years or so, predominantly male. They really wanted to look at that annualized rate of moderate or severe COPD, but they also looked at a change in pre-bronchodilator FEV1, as well as a St. George's respiratory questionnaire and an evaluating respiratory symptoms in COPD questionnaire. Both of these questionnaires, the lower the score was, the better the patient's symptoms were and the better their quality of lives were. In the Boreas trial, they matched their power, needed to get their, they reached, I should say, the patients needed to get their power. And so for their results, they found that the annual rate of moderate or severe exacerbations with dupilumab was 0.78 compared to 1.1 with the placebo. The p-value was less than 0.001. They found that 95.1% of the patients in the dupilumab group completed the 52-week trial versus 93% of those in the placebo group. So overall, a great drop in the moderate or severe exacerbations, as well as a slight decrease in the time to first to moderate to severe exacerbation, as well as they saw a decrease in the pre-bronchodilator FEV1 at week 12. And they saw that improvement last not only from as early as 2 weeks, lasting out through week 52. And these results were also statistically significant. They did also see a decrease in both the St. George's respiratory questionnaire and the evaluating respiratory symptoms questionnaire, a drop in both of those scores, both statistically significant, no major adverse events, no major differences in any AEs that the patients experienced. And so from this, they proceeded on to the Notice trial, very similar to the Boreas trial, just sort of further confirming efficacy and safety in these patients. Very similar in terms of patient age. Again, looking at that rate of moderate to severe COPD, similar safety endpoints being assessed. They were able to have the amount of patients enrolled to reach their power. And again, primary endpoint, they found that the rate of moderate or severe exacerbations was greatly decreased compared to the placebo while on that triple therapy. In this one, about 73% of patients completed that 52-week study period compared to about 72% for placebo. Again, another slight decrease in that time to moderate to severe exacerbation. And then similarly, the FEV1 pre-bronchodilator at 12 weeks, there was that great increase in it, and it did sustain through week 52, and they were statistically significant. Similarly, they did have the decrease in the St. George's Respiratory Questionnaire and the evaluating respiratory symptoms, decreases in both, showing the improvements in the individual symptoms. And from these trials, they did confirm and conclude that add-on dupilumab really did reduce the rate of exacerbations, increase lung function in patients with COPD with type 2 inflammation, as indicated by blood eosinophil counts. And these were the two studies that helped to get that FDA approval for Dupixent for that. The other product that we have is ensifentrine, which is brand name Ohtuvayre. This is a novel PDE3 and PDE4 inhibitor that was approved in June 2024. Does have to be given via a standard jet nebulizer twice daily. However, the trial that they did, it was symptomatic moderate to severe COPD. They had a post-bronchodilator FEV1 between 30 and 70. However, the patients were on no long-acting maintenance therapy or only on LABA or LAMA maintenance therapy, which if you're looking at moderate to severe COPD, that's not appropriate therapy for those patients. So it wouldn't seem likely that you would find that in the actual world. But anyway, in their trials, they did find that there was an increase in the average FEV1 area under the curve in both the ENHANCE-1 and ENHANCE-2 trials, and it did reduce the rate of moderate to severe exacerbations over 24 weeks, and it was statistically significant in both those trials. However, the limitations, it has only been administered to less than 3,000 people globally, and that's because it's administered through the manufacturer. As of yet, it's difficult to decide which population this will be administered to, because again, we're saying moderate to severe COPD, yet in the study, these individuals were not on dual or even triple therapy. So it's hard to determine, would this be beneficial as an add-on or what its true benefit is. And again, cost and insurance, it's about $24 to $25 a dose. Patient needs 2 doses a day. It's about $50 a day. So it is expensive. Tezepelumab is our next one, May 2024. Currently FDA approved for severe asthma. They are looking at it in moderate to severe COPD with a broad range of eosinophils. This is an every 4 weeks study. As of right now, they are looking at an annualized rate of moderate to severe exacerbations. It was not statistically significant at the end of that study. However, it was well tolerated. So they are still looking at this, and they're promoting the clinical benefit of it, although they are showing that it was not statistically significant. They did say that greater reductions were observed with those who had a blood eosinophilic count greater than 150 overall, compared to the main population. So we'll see. They may still consider other trials going on. There's also tozorakimab, which is going on in the Oberon, Prospero, Titania, Miranda, and itepekimab, which is in the AERIFY and AERIFY-2 trials. And so there's a lot coming out in the pipeline, but where do we come into this? And really, pharmacotherapy is key, but we need to help with device selection and adherence. And so there are 22 different inhaler devices available. There's nebulizers, there's metered dose inhalers with or without spacers. There are MDIs, there are soft mist inhalers, there are DPIs. And really, we should be assessing our patients at every single visit if they can handle this. Because unfortunately, if they are not able to utilize their inhalers properly, they're not getting their medications. And that's the worst part of it. And so we should be making sure that their inhaler technique is correct. Because again, if they're not receiving their medication, what's the benefit? So is the medication appropriate for the class? What formulation or device is available for them? Can they access it? Is it too expensive for them? Can they handle the device? Are they physically able to open it versus can they do a swift inhale versus do they need to do a long, slow, steady out exhalation? If it's a DPI, does the patient have a sufficient peak inspiratory flow? That peak inspiratory flow is so important, and it's necessary to disaggregate and aerosolize powder formulations. And a lot of times with DPIs, you need to have at least 60 liters per minute. And so if we're not even assessing peak inspiratory flow in patients, we don't know if they're going to be able to use these. So device errors, more than 67% of patients are making at least one error when using an inhalation device. With MDIs, it's mostly coordination or speed and depth of that inhalation. They're not holding their breath post-dose. With a soft metered inhaler, they're not preparing the dice appropriately. They're not fully exhaling before inhaling, or they're not maneuvering appropriately to do it. With the DPI, they're not preparing it appropriately. Again, they're not fully exhaling or not holding their breath. And these are all factors that could increase our patient's FEV1 or decrease the FEV1, could reduce, increase their exacerbations, and will then increase our healthcare costs. And this is something that I thought was just really interesting. A study by Lowe et al. Looked at suboptimal inspiratory flow rates, looked at patients being discharged from the hospital in North Carolina. Most of these patients were being discharged on DPIs due to the fact that they required fewer steps than an MDI. But the majority of these patients, 52%, had a suboptimal peak inspiratory flow. And of those patients, they had greater CAT scores, they had higher rates of a 90-day COPD readmission, and they had higher all-cause readmissions. And so not assessing our patients for the proper, appropriate peak inspiratory flow, not looking at are they able to use their inhaler is so critical when assessing our patients for their inhalers. And again, in addition, are they able to access their inhalers? Inhalers are expensive. They may need financial access to improve adherence. You may be able to give them an inhaler at discharge, but are they going to be able to pick that up at a refill? They can get it through and biologics. They may be able to get it through a free trial, but can they get it going forward? So these are things that we as pharmacists can all assist with. There are patient assistance programs. Luckily, some manufacturers have a $35 inhaler cap. There's a dispensary of hope or needy meds or good RX or RX outreach, things that we can just keep in mind. Our biologics, we need to keep in mind our immune status of our patients, the live vaccines. Are they pregnant or want to become pregnant? Do they have needle phobia? Because that's a major factor when it comes to them administering their injection. And this is just transitions of care, which I'm sure everyone on the call is very familiar with, but making sure medication reconciliation, everything, assessing our patients, continuity of care, making sure that we at every step can hopefully ensure that they're taking their medications and can continue their medications. Smoking cessation, ask, advise, assess, assist, arrange. We all know smoking cessation is a major factor when it comes to our patients. And then our vaccinations, we do want to ensure the vaccinations are up to date. We have that influenza vaccine, pneumococcal, new gold guidelines, actually PCV1, 21 or 20, COVID, RSV, Tdap, and zoster. And with that, I do actually have 2 polling questions, but I know we are very close to it. but if we could. Yes. So a 68-year-old woman with a 50-pack year smoking history of worsening COPD symptoms, chronic cough with copious sputum production despite receiving inhaled triple therapy. She receives frequent exacerbations requiring oral corticosteroids. Her her FEV1 is 53%. Her FEV1 over FVC is 0.6. Her blood eosinophil count is 450. She doesn't have a history of asthma or allergic diseases. What would be the best step at this point to manage her COPD? Would you add azithro? Would you add roflumilast? Would you add dupilumab? Or would you decrease to a LABA or LAMA at this point? Perfect. Looks like the majority picked dupilumab. So with this azithro in this patient, she has a 50-pack year smoking history, but she's still a smoker. I know that could be worded a little off. So with azithro, it's better if they are a previous smoker. She's still a smoker. Roflumilast, it's better if their FEV1 is less than 50. She has an FEV1 above 50 at this point. Dupilumab at this point, she has that triple therapy. Her eosinophilic count is greater than 300. That is exactly correct. That is going to be the next best option. And then we have one other question for you guys. What would be the most important to reduce COPD readmissions in a patient? Is it appropriate pharmacotherapy, smoking cessation, vaccinations, medication inhaler counseling, or all of the above? And as a teacher, I know my boss would hate this question, but hopefully you all get it. Yes, that's perfect. Exactly. All of the above. That's exactly correct. So all of the above. And with that, I leave it if there are any questions, and thank you all for taking the time.
Thank you, Dr. Cabral, for that presentation. I'm not sure with your experience with all of these, monoclonal antibodies that are coming out. I'm assuming most of them need specialty pharmacy access to be able to be either delivered or picked up from patients. Do you see that these are being covered by insurances and easy access for the patients to be able to obtain them?
So we do have a lot of experience with Dupixent at my clinic, and I would say a lot of them, as long as you can show that there is a history of trial of the previous medications, you have the blood eosinophilic count, I do see it being covered. The cost is the limiting factor. And so in that instance, I do see Dupixent My Way coming into play a lot, having the ability to assist with copay coverage for a lot of patients. But thankfully, they are getting covered. It's just cost management for a lot of these patients.
Great, thank you. And there is one more question, I think, kind of related to this. Do you mind going back or repeating the patient assistance program names that you mentioned in addition to
Absolutely.
GoodRx for this?
Yes. Yes. So Dispensary of Hope, there's Needy Meds, there's GoodRx, and there's RX Outreach, as well as GSK, AstraZeneca, and Boehringer Ingelheim have a $35 inhaler cap. So that would apply for a few of the inhalers, which is a plus. And then a few of the manufacturers have their own access programs, as well as RX Assist and RX Hope.
Great, thank you so much. I think that is all the time we have for today.